Let's start today's seminar. Over to you.
So thank you, Dr. Sonal, for the nice introduction, and thank you, Dr. Professor Sumit Gujral, for this opportunity. So I'll share my screen now. Give me a second. So I hope you can hear me well and see my screen.
Yes, sir.
Sir.
Okay. So this will be an interactive session as we commonly do, and students will also tell their opinion on the images already shared. So let us start. Today we'll be talking about the endoscopic biopsies from the lower GI tract. There are many challenges of the endoscopic biopsies because these are very superficial and we cannot see the whole intestinal wall. Like this one, you can see this is only a part of the mucosa. So this is our first case. We'll discuss it with some of the students, maybe some first year student, either Dr. Gulabshan or Dr. Srishti. Any one of you can take this up. So this was the first image and this was the second image, and we asked what is your interpretation. So if you get this type of biopsy, what you will tell?
So it is a normal mucosa of colon which shows Crypt and uniformly distributed and
So you wanted to say the crypts are
That-
there and they are uniformly distributed.
yes,
Then
and
why you are saying it is normal? Why it is not inflamed?
there is equal distance between them.
Okay.
And there is a lamina propria in between them.
So we can see the lamina propria. There are a few inflammatory cells, but when we'll say that these are normal cells and this is not inflamed.
Distance, when distance increases,
Okay.
it shows edema or some neutrophils. Inflammatory cells will show more and more.
Okay. So that was very nice.
There is only there is a inflammatory cells present, but in deeper, if it is present, it will be some other defect.
Okay. So let us see how do we interpret. So what we actually see, this is first we have to see if there is orientation and not. So when the biopsy is oriented properly, so you can, this is a oriented biopsy. So what is the finding? As she has very nicely told, the crypts are evenly distributed, and evenly distributed, when it is oriented, you will see the tall, very deep crypts, and the crypts usually pinches on the muscularis mucosae, what is there. So whole part is the mucosa, and the spaces in between the crypts are usually equal to each other, so that we compare it, this arrangement, with the test tubes which is evenly kept on a rack. And if you take a cross section of this, what you will see, the rounded crypts. So that actually happens when the biopsy is not oriented. We see the rounded crypts. It is a cross section, but still you can determine the distance in between each crypts, that is well maintained, and they are not expanded or irregularly distributed. Okay, that was one point what she told very nicely. Second point is that we have to determine if the mucosa is inflamed or not. So how do we determine that? We imagine a line like this, roughly that will be dividing the mucosa into two halves. So if you see, there are few mononuclear cells like lymphocytes and plasma cells on the upper half, but very few of them or occasional of them are present into the lower half. That means they are more polarized towards the luminal surface. Okay, they are not redistributed downwards. Like the hair also, you can see some lymphoid aggregates also, but this is more towards the luminal surface and some inflammatory cells, but that is not present everywhere, though we cannot say which part is the deeper part because it is a transverse section. So roughly you can see it is only polarized to some part, not distributed everywhere. And as she told, the spaces in between the crypts, that will be increased if there is increased inflammatory cells. So this rule we have to apply, and here already has been spoken. So that means it is a architecturally normal biopsy, and the inflammation is also not great. So this is the evenness, just to show you. So with that, we can ask Srishti to talk about the second case?
Sir, here we can see distortion of the crypt architecture, and we
How
can
do you
also see some.
define the crypt distortion? Already normal we have described. So
Yes, sir.
which finding you are highlighting here as a crypt distortion?
Sir, the depth of the crypts might be increased or decreased.
Depth of the crypt will decrease. That is one point. What else you have to see?
So also the distance between the crypts
Yes. Do
is
you think that is
uneven.
altered here?
Um, yes, sir, it is altered. It is uneven.
But see, uh, this type of distribution, I think I will say this is almost normal. Okay, this part here possibly there is a large lymphoid aggregate that
Yes, sir.
is making you to think it is altered. Okay, this
Yes,
part
sir.
it is normal. So what about the other rule we have talked about? If there is any redistribution of the inflammatory cells or increase in the number of the inflammatory cells?
It will be there in the upper portion of the mucosa, sir.
I cannot hear you.
So it will be there in the upper portion of the mucosa.
But what is present here? It is abnormal or it is normal, like the earlier case?
So it is abnormal only. We can see
Okay,
it
so
throughout the.
you said the number has increased possibly. Okay, I agree. And there is some redistribution, as you can see, but there
Yes,
is some clustering of the mononuclear cells into the deeper part. Another
yes,
important thing is the shape of the epithelium.
Denuded.
Normally, you all know these are tall columnar cells. This is not denudation. Denudation is the absence of the epithelium. This is what you are seeing epithelium, but it is not that tall columnar. It is now has become low cuboidal to low columnar. Okay, and it only happens when there is some mucosal injury going on. Okay, so that indicates there is something going on into the mucosa and there is some inflammation. So at this power, we can say the mucosa is possibly inflamed. So already what you have to see under microscope, first architecture, then you have to see, apply those rules, and you have to see if the mucosa is inflamed or not. So this is another picture from this case. Same rule will apply. Now in this focus, what we can see, there is a lot of inflammation actually. But though there is some shortening of the crypts, actually the crypts, when there is distortion, crypts will become shorter. But we have to also determine if it is properly oriented or not. Here it is partly oriented. So in those cases also you may think that the crypts are short, but they are not actually shorter. Okay, because here you can see the surface. Also, we cannot see the muscle bundles here properly, and possibly it is obliquely cut. So that's why it is it is appearing that the crypts are shorter. But definitely the numbers, there is redistribution of the inflammatory cells, and number of the inflammatory cells has increased. So from this finding, we can say that the biopsy is inflamed definitely. What you can see in this picture, Srishti, this was also provided. Anything, any finding here?
so there
Apart
is
from the,
erosion of the mucosa.
how do you define erosion?
So discontinuation in the epithelium in
See,
the.
discontinuation is not equal to erosion. For erosion, you have to see neutrophilic infiltrate without any underlying formation of granulation tissue. So what is the basic difference from ulcer? So there will be discontinuation of the epithelium in ulcer, in denudation also, as well as in erosion. But ulcer, as you know, there will be exudate, there will be granulation tissue underneath. Erosion is a early smaller version of that, and here we don't see usually erosion, but neutrophil and neutrophilic exudate you might see. So any other finding in this focus about the cells, type of cells? This is higher power image. Can you see these cells? What are these? These cells? Neutrophils. So what does neutrophil indicate?
Acute
Acute
So
inflammation.
it is an acute or active injury. Okay, we should use this type of term. So what we have seen in this biopsy, there the mucosa is inflamed. The architecture is not very definitely altered because here it is normal. Here also, though there are some shortening of the crypts, but there is no branching, active branching we can see, and the spaces in between the crypts are still maintained. And however, we can see neutrophilic infiltrate. So what will tell and what will stamp these cases? So it is inflamed, but no architectural distortion.
Acute active colitis it can be.
Very nice. So we have seen polymorphs infiltrating the epithelium, so that makes it active or acute colitis. We use few terms, like there is a term called ACLS, that is acute self-limiting colitis. Okay, and also we use another term, acute infectious type colitis. So these are commonly used terms, so that you can use in such cases when there is no alteration of the crypt architecture, but you can see active polymorphonuclear cell infiltrate. And whenever you know there will be polymorphonuclear cell infiltrate, as a reaction, what we see, there will be loss of goblet cells, and also the epithelium will lose its height. ठीक है ना? So that's why you are seeing flattening of the epithelium. So this is the same space or place where the hyper image was taken, and it is showing the polymorphonuclear cell infiltrate. So that makes it acute infectious type colitis. So we have seen normal, we have seen acute infectious type colitis. So saying so, what is the importance of the Crypt architecture? Here one I will describe you. So this is the normal architecture already we have described. So whenever these test tubes are very irregularly or erratically kept, so that is, so the spaces in between will be increased. Focally, the crypts will become very close to each other, and we can see also branching, or there is some will break and there will be branching of the test tubes. So similarly here we can see the vertical branching, we can see the side branching. In between the crypts, the spaces has increased. Also, in addition, the mucosa is inflamed. So what does it indicate? And here, see the mucosa, we can see definitely it is a oriented fragment, because you can see the muscle, you can see tall crypts, and here side by side you are seeing very short crypts. So we are very definite that it is not artifactual one, and the crypts are short. And these are side branching, and these are side and vertical branching. So what does it indicate? Any one of you? So any crypt distortion is indicative of what? It is indicative of chronicity. So what did we learn today? Neutrophilic infiltrate into the intestinal epithelium, small bowel and large bowel, is a feature of activity or active inflammation. And alteration of the architecture for us, it is indicative that the inflammation is chronic. So is that clear? So if there is architectural distortion, we'll call it chronic colitis. Okay. Sometimes, other than this architectural distortion, you can see the normal intestinal epithelium may be replaced by other metaplastic epithelium. Like here I am showing you pyloric metaplasia, that is also a feature of chronicity. So if you see architectural distortion, or if in ileal biopsy you are seeing pyloric metaplasia or surface villiform change, that only tells you that the disease is chronic. So many a time you will see the chronicity and the feature of activity, they will be present together. So what do it term we use then? So chronicity plus activity, both features are there. So which term we should use? Anyone? So it is a chronic active colitis. Do you agree? The features of chronicity is there as well as activity is there. So this type of scenario we call it is a chronic active colitis. So this is a schematic diagram just to show you how the chronic active colitis looks like. But if we now correlate with the etiology of the disease, you will see there are so many. Actually, this is not the complete list. So chronic active colitis we can see in IBD, both in UC and Crohn's. We can see in tuberculosis. As a student, you must not forget these two differential diagnoses. Any persistent infection like Shigella, Salmonella, Yersinia, everything can cause chronic active colitis. Microscopic colitis also can sometimes cause this type of changes. Chronic ischemic colitis can cause altered architectural distortion. Radiation-induced changes and diversion colitis chronic, that can also show you chronic active changes. So that means that whenever you are seeing this type of picture under microscope, that is not specific for any disease. Is that clear? Okay. So chronic active colitis is a histological finding. It is not specific to any disease. Now, what are the features we have to see to what differentiates a chronic IBD from a chronic non-IBD pathology, what we already discussed. Any one of you? Very quickly. Okay, so this is one image. What all you can see, this is again oriented, and the crypts are branching. There are short crypts. So if the crypts become short, this zone is called what? This is anyway towards the base. So we call it a basal zone of the mucosa. And you can see, due to the presence of ICAM receptors and all, or most of the plasma cells, they will be polarized in this area. So this is called basal plasmacytosis. It can be focal. When it is focal, you can see cluster of 5 or more plasma cells. It is called focal basal plasmacytosis, or you can see band-like basal plasmacytosis like this. Then it is called a diffuse basal plasmacytosis. In addition, in IBD also, if along with basal plasmacytosis, we seen eosinophilia of the mucosa, that is another suggestive finding. That means if we see in this zone basal plasmacytosis eosinophilia, we call that eobaso, or eobaso if it is present in multiple biopsy fragments in your segmental biopsy, then the possibility of IBD becomes very high. Understood? So what will be present in the background? Chronic active colitis like changes. In addition, we have to then see basal plasmacytosis and then eosinophilia. Only eosinophilia can be due to other causes. So if you combine basal plasmacytosis with eosinophilia along with the background changes, then you can think it may be IBD. That is also not a specific diagnosis. I will come to that. And there are various recommendations from the BSG. It came in 2013 that clearly told
Sorry
that
to
basal
interrupt you.
plasmacytosis is, yes?
Sir, there is a request to use laser pointer.
I cannot hear you. Yes?
Sir, can you please use laser pointer? Will be more visible.
Laser pointer.
Yes.
I'll try. Can you see now?
Yes.
Okay.
And sir, there was one request. Please show Crypt.
There are some echoes. I cannot hear you.
Vishnupriya, please mute yourself.
Yes.
Sir,
Can you please repeat that?
Yeah. Yes, sir. Please show Crypt branching again. Sir, there was one.
Okay. I will show that. We'll see those features in subsequent cases also. I will discuss with the students. So these are actually crypt branching. So these are called short crypts because they are not reaching up to the muscularis mucosae. When you will see two crypts, they are faceting each other like this, very close to each other. That is indicative of lateral branching, and horizontal branching just look like this. So short crypts, this is horizontal branching, and these are side branching. And then we talked about the basal zone, which is created when there is short crypts. This zone will appear, and you will see a lot of plasma cells there. That is called basal plasmacytosis. And these are actually the eosinophilia. If you present them together, that will help you to ascertain if it is IBD or not. And there are BSG recommendation. Also, we are near to publishing our recommendations. So this is a very strong finding which help us to identify differentiate IBD from non-IBD. So please try to look for this finding in all cases. Okay. And also please remember, whenever a biopsy is taken, you have to also know since when the patient is symptomatic. If a patient has developed symptom just 10 days back, you may not expect to see crypt distortion as well as basal plasmacytosis. So if we see the chronology of the findings, what appear, so basal plasmacytosis is the earliest one that usually appears by 3 to 4 weeks. And crypt distortion and all other features what we described, that may take at least 4 to 6 weeks or 2 months or so to appear. So if you have confusion, if it is a very early biopsy, it is IBD or not, you may discuss with your clinician and ask them to repeat after a few weeks. Okay, that is usually the protocol. And these are our studies. So I will show you just to compare between the IBD and ITB, and you can see mucosal eobaso is significantly higher in cases of IBD. In some cases of ITB, you are seeing because basal plasmacytosis, you have to neglect only in one anatomical site, that is ileocecal junction. In ileocecal junction, due to anatomical constriction, we see some eosinophilia and some basal plasmacytosis in physiology or in normal patients also. That's why, and ITP, most of the cases we diagnosed on the ileocecal biopsies. That's why you are seeing some few cases we have identified EO-baso, but you can take it if you are seeing colonic segmental biopsies. If you identify these features, then it will help to you to differentiate IBD versus non-IBD. So please remember this cartoon I have made for you. So what are the histological features that will favor an IBD? First is must have architectural distortion, because it is a chronic disease. Based on the activity, if the disease is active or not, you can find neutrophilia, ulcer, crypt abscess, cryptitis. And differentiating feature from non-IBD is the basal plasmacytosis and then eosinophilia. Not only eosinophilia, basal plasmacytosis and eosinophilia. So with that, I will invite Supriya, if she is there, to discuss the case 3. This is 31-year-old female, ileocecal biopsy, and the question was, it is TB versus GITB. Or sorry,
Yes,
sorry for the typo. It is actually Crohn's versus GITB.
yes, sir.
So
I
what
could
you can
appreciate.
see?
Yes, sir. I could appreciate 4 bits of tissues. Where on further magnification, I could appreciate mixed inflammatory cell infiltration in the lamina propria.
So
I could appreciate.
before you go ahead, can you see my leads? So can you see on the screen? I have asked first feature is architecture. Then you have to
Yes, sir.
decide if the mucosa inflamed or not. Then you
Yes,
have
sir.
to
There
see
is.
if these changes are focal or diffuse. So you have to follow this chronology or this sequence in all cases. So please tell accordingly.
Sir, there is presence of presence. There is distortion in the architecture. I could appreciate the abscess and cryptitis in these cases, where I could appreciate the shortening of the crypts, decrease in the distance between two crypts, and there is also branching of the crypts here. And I could appreciate some focal inflammatory cell infiltration in these 4 bits of tissues, in which I could appreciate lymphocytic infiltration and even the eosinophilic infiltration also.
Okay, we'll go into higher power pictures. So what
Yes,
we should tell number of the fragments first.
yes,
Then
sir.
you have
4.
told the architecture is distorted. Very nice. But you have to also ascertain if these changes are diffuse or it is focal. So what do you think?
Focal. This is focal, sir.
Very nice. So
Yes,
if I look at this area, so possibly though it is not oriented, the architecture is maintained.
maintain.
However,
Yes.
if I look at this area is architecturally maintained, but there is some branching is there. At places the crypts are shorter and the space are also unequal. Here the architecture is possibly maintained. Here it is distorted. Here
Yes.
again architecture is maintained, and possibly these are the areas of crypt branching. Okay. So that's nice. And the other question was if the mucosa is inflamed or not. And you have very correctly said there is redistribution and increased density. So it is inflamed. So we'll go into the next power picture. So we have to now, there are a very specific clinical question. We have to decide it is IBD or it is ITB. Okay.
Yes, sir.
Now look at the higher power picture and tell what you can see. These are the lead questions. Okay. To help you.
Yes, sir. I could appreciate mixed inflammatory cell infiltration in the lamina propria, which are the lymphocytes, and I couldn't appreciate plasma cells much in these slides.
So what are these cells?
So basal
So these are lymphocytes where the
lymphocytes.
there are many
Yes, sir.
plasma cells also in between. Okay. So what I told, the basal plasmacytosis can be band-like or it can be very focal also. And what is the definition? If you see 5 cell or more plasma cells just below a short crypt, that is focal basal plasmacytosis. Okay. So that is there, and you have said nicely that there is eosinophilia. So EO-baso is present. Here also you can see the same thing, but here it is not possibly properly oriented, but this area we can see many plasma cells. Can you see that? Just above the muscular is mucosae. Okay.
Yes, sir.
Okay?
Now we can appreciate.
So
Yes, sir.
that indicates this is basal plasmacytosis. So now
Yes.
till now what we have determined, it is chronic or acute inflammation?
Chronic inflammation, sir.
Chronic patchy inflammation. So till
Patchy
now we can
inflammation.
say it is a patchy chronic colitis with basal plasmacytosis and mucosal eosinophilia. Now this is the next picture for you. What you can identify?
Yes, sir. I could appreciate here the crypt distortion and the neutrophilic infiltration inside the lumen of the crypt, that is called as the crypt abscess. So I could
Uh,
appreciate the cryptitis and crypt abscess both, and mixed inflammatory infiltration in the lamina propria.
Wonderful. So very nicely you have said the spaces in between the crypts have increased. There is a lot
Yes,
of
sir.
inflammatory cells, and these are the features of activity. So be it the cryptitis, crypt abscesses, ulcer, erosion, any one of them will qualify for activity. So now what we have seen, it was a chronic. Now we have seen activity also. So what name we should give? Etiological diagnosis.
Chronic active colitis, we can give it.
It is a chronic active colitis. That is very nice, but it is a patchy chronic active colitis, isn't it? So
Yes,
this
sir.
is patchy chronic active colitis. Now, can you tell from these findings it is a tuberculosis or it is a Crohn's disease?
So for that, we have to search for the granuloma,
Yes, granuloma.
which,
So we
yes, sir.
discussed just few slides back that if you identify basal plasmacytosis, it will
Yes, sir.
favor ITP, it will favor IBD. So what about
IBD,
that?
yes. Yes, sir, we can say it as IBD, but
No, you cannot say
only
that.
the
You cannot say that in this case because that is, you have to also look at the site of biopsy. What I told just few slides back, if it is a
ileocecal biopsy.
ileocecal
Yes, sir.
biopsy, you cannot rely on the eosinophils as well as basal plasmacytosis. That's why we always ask for the clinician, you take segmental biopsies. Segmental ka matlab, you take two fragments from ileocecum junction. From the different anatomical site of the colon, you take two biopsies and also two biopsies from the rectosigmoid area. So total 5 sites, 2 fragments each from each site. So if you have this type of distribution, then only you can say if this basal plasmacytosis is due to the ileocecal junction or it is a part of the disease, isn't it? So
Yes,
if
sir.
only ileocecal biopsy you are receiving, like in this case, even if we are identifying basal plasmacytosis and eosinophilia, and it is a chronic active colitis, we may not be able to differentiate between tuberculosis and GI tuberculosis and Crohn's disease. So let us.
Sir, there is one question. Why patchy?
Yes,
Sir, why patchy colitis?
it is patchy because either you have to look at low power. The patchiness can be because of the architectural change, because here I showed you at places the architecture was normal, at places it is distorted, or the patchiness can be also because of the density of the inflammation. Okay, if I compare between this area and this area, the density also differs. But here very glaringly you can see the architecture is maintained at some places where it is altered in the other places. That is that is how the patchiness is identified on biopsies. Okay.
Thank you.
So we are talking about the Crohn's disease and tuberculosis. Most of them are actually very common in the ileocecal junction, as you can see. That's why most commonly these sites are commonly biopsied, okay, clinically. But though they are most commonly biopsies are taken from this area, we cannot differentiate because now you know the limitations. However, if
Yes.
you look at the next common site that is also common to each other, these two diseases, the rectosigmoid area. These are the most common site. If you are doing a sigmoidoscopy, you will only have access to this area and you will get biopsies from this area. So you have to remember the most common site is common in between these two diseases, and also rectosigmoid area, which is most commonly sampled in sigmoidoscopy, not full colonoscopy. Both the diseases can be seen. Okay, so that's why segmental biopsies are important. So what are the findings that are common between these two diseases? We have already discussed. One is both the diseases are chronic, patchy, and both the diseases can be uh, patchy, chronic. Here you can see the patchiness of the inflammation. This is denser and this is very mild inflammation. And here the architecture is abnormal. Here also architecture is almost normal in these two places. Here the inflammation density is much more than the other areas. That's why it is patchy. So chronicity is common to both the diseases. Patchiness can be common to both the diseases. In the cecal fragments also you can see at areas the inflammation is very mild. At other areas the inflammation can be denser. Activity can be seen in both the diseases, and in both of them what we can see, the ulcers can be very deep, serpiginous, rail track like ulcers, and they can burrow into the deeper layers, and also they can perforate through the wall. But though most commonly we see fistula formation in Crohn's disease more than the tuberculosis, but intestinal rupture can be seen both the diseases. Okay, and because of the specific site that is usually sampled, basal plasmacytosis can be seen in ileocecal junction, and in Crohn's disease also in other areas you can see basal plasmacytosis. Inflammation into the deeper layer beyond the mucosa can be seen in both the diseases, and stricture formation can be common in both the diseases. So none of these features actually will help us to identify or differentiate these two findings. So what are the findings that will help us to differentiate? You have very correctly said granuloma. And
Yes, sir.
what are the features? Now we have to also qualify the granulomas. Like here, you have to see the size of the granuloma, if it is more than the diameter of a single intact crypt or not. That is called macrogranuloma. Or if you talk about a size when it is more than 400 or 500 micrometer diameter, we call it a macrogranuloma. So if you see macrogranuloma, chance of tuberculosis is higher. If you see multiple granulomas, even in one anatomical site biopsy, if you see 5 or more granulomas, macrogranuloma I am talking about, chance of tuberculosis is very high. If the granulomas are confluent to each other or they are very close to each other, then chance of tuberculosis is high. If you see necrosis, definitely the chance of tuberculosis will be higher. Giant cells though can be seen in both the conditions, it is more common in tuberculosis. And another thing is, though we not very commonly sampled in mucosal biopsies, but deeper granulomas, if you find this type of macrogranulomas in the submucosa or into the upper part of the muscle layer, then chance of tuberculosis is further higher. So all these qualifying factor you also have to document in the report. Now talking about the microgranuloma, where the size is equal to or lesser than a intact crypt, or less than 100 micrometer, that can be seen in both the diseases, in Crohn's disease and tuberculosis. But there is also some differentiating feature you can see in some cases, like mostly in Crohn's disease, the microgranulomas are ill-formed like this. Ill-formed matlab they are not button like what microgranulomas we are seeing in a case of tuberculosis here. Okay, so how does the Robbins define a granuloma? It is a very basic subject. It is a very well circumscribed collection. Okay, so that is actually a definition of tubercular granuloma. That doesn't match with a very well circumscription you don't see in a Crohn's granuloma. Okay, so these are loose granulomas, so that we commonly identify in Crohn's, but in tuberculosis microgranuloma can be seen, but they are usually well formed and button-like, and sensitivity of the ZN stain is very low in intestinal tuberculosis because it is a possible ancillary disease unlike lung and other areas. So you will only find once a while acetous bacilli, but when it is positive, then it is definitely tuberculosis. So this picture was also given in this case. So what you can see in this picture?
Sir, I
Sorry
can
for this.
appreciate. Yes, sir.
Yes.
Can appreciate one ill-formed granuloma there. It is having central necrosis and some epithelial cells are present, and I could not appreciate giant cell anywhere here. So it is a
Okay.
ill-defined granuloma
So
present
the
there. Yes,
first tell me, it is a ill-defined or well-defined?
ill-defined, sir.
Very nice. So you have not seen giant cell. That is correct.
Yes, sir.
Where is necrosis? We
In
can
the
see
same.
nuclear detail everywhere. It is very easy to ascertain. You can see nuclear detail everywhere in this space. So there is no necrosis. Now the point cryptolytic and non-cryptolytic. What do you understand by that? So here you can see an intact crypt. Can you
Yes,
see
sir.
or not? So
Yes, sir.
if you see, so in Crohn's disease, the microgranulomas, they will be always just beside a intact crypt. That's why it is called non-cryptolytic granuloma. Why we use that term? Because this type of ill-formed granuloma can also be found in acute infectious colitis or even in UC. Why? Because if there is a, suppose if there is a crypt abscess and the crypt have ruptured, so against the mucin there will be histiocytic collection. So that mucin granuloma can be mistaken as Crohn's granuloma. So that's why if you find there is a ruptured crypt or there is no crypt in that area, but you are identifying a loose granuloma, that is usually not a granuloma of Crohn's disease. But if you find an intact crypt along with a loose granuloma, that is usually a finding of Crohn's disease. Okay. Nothing is very specific. You have to do permutation combination between all these findings. So what we can say, we always use two-liners for our interpretation. This is the basic morphological diagnosis that you should always understand and write. So this is a patchy disease. It was a chronic active colitis, no doubt, with focal basal plasmacytosis and eosinophilia, though we had doubt it is site-specific or not. But based on other features, now we'll write the etiological diagnosis that it is favoring Crohn's disease over tuberculosis. Okay, and you can favor in this case, because always please remember histological diagnosis and IBD we can favor, but the when it is confirmed, it is only confirmed after radiological and clinical correlation. Okay, be very clear. So it is a favoring, so we can favor Crohn's disease in this case because of this particular finding. So another student can come up. Anne-Marie, can you describe this?
So there is a question, what do we say when we have neutrophils in the surface mucosal epithelium?
So like the second case, we have shown you neutrophil into the surface epithelium only. So the question is valid, very pertinent, because sometimes because of the bowel preparating fluid, you can see an occasional neutrophil into the surface epithelium. But you have to see there are sizable numbers or not. Usually the activity also has been defined. If you identify at least 2 or more neutrophil into the lamina propria or into the epithelium, then only we use the term activity. Okay. So even if neutrophilic infiltrate you see in the surface or into the deeper crypt, it is equals to neutrophilic activity. Okay. So Anne-Marie, can you describe this? It is also ileocecal junction biopsy, and the question is same. Always you will see these two differential diagnoses, TB versus ITB. Sorry, CD versus ITB.
Sir,
What are your findings?
Sir, there is in this I could see uh, 3 fragments, and mostly it shows chronic inflammation where the inflammation is patchy, and I could see the necrotic areas.
Possibly. So you said inflammation is patchy. I hope everyone now can correlate. So this is a area of dense inflammation. This is an area which has very less inflammation, and also the crypts are perpendicularly situated on the muscularis mucosae. That is how we determine if the small bowel is oriented or not. The surface is actually here denuded. And do you think this is the area of necrosis?
Yes, sir. Yes.
Okay. Definitely we can say there are some areas, geographical pale areas, that we'll see high power. So let us go into high power. What you can see here. So this is the ileal fragment. Similarly, this is a patchy inflammation. And anything else? Can you see any ulcer or anything in this power? Or you want to go to higher power? So let us go into higher power. So what is this area indicate? See, there is some epithelium, if you can see. But rest of the areas we are seeing like this. So what does this area indicate? This is your
Sir,
PL geographical area. We'll come to that. This is?
the area of ulceration where the
Exactly. So that is how we defined. We have to identify this residual epithelium. Here also we can see epithelium, but here there is breach of the epithelium. In addition, what we can see, there is dense neutrophilic exudate, and underlying there is inflammatory granulation tissue. So this is definitely an area of ulceration. So we have to identify these areas. Possibly these are also the same areas, and there are some geographical areas. What you can see in this, John? So these are the crypts shown in high power. Anything you have identified?
sir is
What are these? These eosinophilic?
Epithelium.
Yes. Can you repeat, please? What are these eosinophilic spots here on the crypt? Here also. So Paneth cells can
Pilot
be
cell.
okay,
Yes, pilot cell.
but though Paneth cell metaplasia can be seen in ileocecal region also, we can see it is definitely part of the pathology when you see this finding on the left colon, not on the right colon. Okay, so please remember that. So anyway, what we could tell at this point, there is activity and there is chronicity, that is patchy. So again, it is a patchy chronic active disease. Let us see further images. So this is patchy, the chronic active colitis. That will be your microscopic finding at this stage. Now what you can see in our hair power. Here, anything?
Sir, any high epithelial levels?
That you have to tell me very confidently. What you are seeing, these are the same zone, huh? Pillar zone, what we have seen. So these are actually the epithelioid cells, and this is a large area where the epithelial cells are reaming this area, and there is some necroinflammatory exudate into the center. So possibly these are all granulomas which are confluent to each other. Possibly this is another epithelioid cell granuloma, and where we are seeing these granulomas, now you have to correlate with this. Possibly this is deeper down. So this is not very superficial granuloma because mucosal surface is here. So at least it is into the submucosa, and possibly this is confluent because this is a large one. And this is the other fragments. If you see on lower power, we can see more granulomas like this. So number of the granulomas we have talked about. You also correlate with the size of the granuloma. So what do you think? It is a tuberculosis or it is a Crohn's? What we can favor in this case?
Considering the size of the granulomas, which are macro and confluent, and
Yes.
more into the deeper side, it could be TBs.
So you can favor, and so you have to use these specific terms. So what would be our morphological diagnosis? It is a patchy chronic active ileocolitis because there are colonic fragments which are completely ulcerated with multiple large confluent epithelial cell granulomas noted in submucosa. So etiological diagnosis is favorable of ITB. Is that clear? So this is how we should approach these biopsies. That saying so, we have now know what is very classical to tuberculosis, what is very classical to Crohn's disease. But if you look at the data, not only our data, but if you look at the literature also, you will find some macrogranulomas can also be found in Crohn's disease. Here the percentage is slightly higher because of the selection bias, but once a while you can also see deeper large granulomas in Crohn's disease, though we favor initially it is a case of the tuberculosis is favored, but the patient don't respond to ATT. After 2 months, another biopsy is taken. Similar findings. Sometimes the ulcer progresses, there is fistula appears, okay, and phenotypically now they are Crohn's disease. So after repeated MDT and discussion, these cases are again reclassified as Crohn's disease. That is how the protocol says. So what did you learn? Macrogranulomas and deeper granulomas are very classical or more classical of the intestinal tuberculosis, but rarely can be seen in Crohn's disease. And however, initially we cannot favor a Crohn's disease. So after treatment trial only on repeated biopsies, we can assess them and discuss them. Okay, that is how we analyze these cases. Also, please remember, this is another full whole mount biopsy or section from the ileocecal region. You can see the ileal mucosa, you can see the colonic mucosa. The identification of the granuloma also depends on from where you are taking the biopsy. You have to ask your clinician if the where from the biopsies were taken. See, this part is not very much inflamed. Here ulceration is there, it is inflamed. So granulomas are actually will be present into the inflamed area. Okay, if you look at the literature, I will show you. So if the biopsy is not taken from the areas of erythema and ulceration, endoscopic areas, so you will possibly not identify the granulomas in those areas. So non-identification of the granulomas doesn't rule out tuberculosis unless any other specific finding of Crohn's disease is there. Okay, is that clear? So we'll go into the case 5. So Vishnupriya, can you very quickly tell us? So the leading question I will put like this.
Yes, sir.
Related to previous case, there is question, what about possibility of granulomas in draining lymph nodes?
Yes, but we are discussing today about the endoscopic mucosal biopsies. So in 99.9% cases, you will not be getting a lymph node excision in such cases. But if it is a diagnostic challenge, later one lymph node can be excised. And if you find a granuloma in the lymph node, and also all features will be same, the confluent granulomas, necrotizing granulomas, chance of tuberculosis will be higher, but rarely macrogranuloma also has been described in adjacent draining lymph node in Crohn's disease also. So if you are lucky, you are having a lymph node, you are seeing a necrotizing granuloma, again you will favor a tuberculosis. But if you think after multiple trial and discussions, the patient is phenotypically Crohn's disease, not responding to the ATT, then you have to reconsider if it is a phenotypically Crohn's disease, but morphologically it is behaving like or showing you features like tuberculosis. Okay, so those rare scenarios may appear, but you should first remember the classical ones. So Bishnu Priya, so these are rectal biopsies.
Sir? Yes, sir. I
And
could
these
see
are before you start, these are actually segmental biopsies, not only taken from the rectum, though the patient had rectal bleeding and tenesmus, it was taken from all anatomical sites of colon. Okay?
Yes, sir. I could see multiple tissue bits with the colonic mucosa. The architecture of colonic mucosa is distorted here, and there is diffuse inflammation, sir. The
And
lesion is
architectural distortion also you have to keep in ask in your mind if it is diffuse or it is patchy. And inflammation also and architectural changes also. So comment about both. So what overall, what do you think? The disease is patchy or it is focal or diffuse or patchy?
it looks diffuse, sir.
Yes. So if you look across all the fragments, architecture is also distorted everywhere. And you are seeing similar density of inflammation present everywhere. So it is a diffuse, chronic, inflammatory colitis. Can we say that?
Yes, sir.
Okay. Any other observation at this hour? What else? What we did not discuss till now? Ulceration is there. That we will see in the higher power. So any other things? So what are these, Vishnu Priya?
Sir,
These areas?
looks like plasma cytosis, like
No, plasmacytosis at this power we cannot say. If you see a blue cluster like this, what commonly we'll think?
lymphoid
Lymphoid
aggregate.
aggregate. Exactly. So these are known as the basal lymphoid aggregates. And lymphoid aggregates, as you know, you can see that from jejunum up to the right hepatic flexure very commonly. But if you are seeing in most of the left colonic biopsies, distal colonic biopsies, multiple basal lymphoid aggregates, that is another finding which favors a possibility of UC along with all other features like diffuse chronicity, diffuse activity. Okay, so basal lymphoid aggregate into the left side of the colon will favor a possibility of ulcerative colitis. So what you can see on higher power. So similarly, mucosa is inflamed, distorted, basal lymphoid aggregate. Anything else you can comment on this? So any basal plasmacytosis, any eosinophilia, let us see in high power. So this is basal lymphoid aggregates. What else?
Crypt distortion, like crypt.
That we have discussed. I am specifically asking you if there are eosinophilia and basal plasmacytosis, because now it is a chronic active, there is ulceration also. Okay, chronic active colitis, we need to differentiate between an IBD and non-IBD. Eosinophilia, yes or no? Look at the color of the cells. What do you think? Reddish brick color cells. Can you see here? Lot of them.
Yes, sir.
Okay.
Some eosinophils have been increased.
And what about basal zone? Normally basal zone is not there because I showed you the normal. Normally the crypt are deep and they pinches on the muscularis mucosae. So what is basal zone? When the crypts are short, a space is created between the muscularis mucosae and the short crypt. And there you have to see basal plasmacytosis. What do you feel here? So these are the collections of lymphocytes and plasma cells. You have to obviously go into further higher power to look plasma cells are there or not, but they were there. So this is actually the zone of basal plasmacytosis that is there, as well as eosinophilia. So can we favor a possibility of IBD on this based on our discussion?
Yes, sir.
Okay. So what was the morphological finding? It is a diffuse chronic active ileocolitis, and we'll comment on the report that with basal plasmacytosis eosinophilia, and the features are favorable of ulcerative colitis. Is that clear? So this is how.
Yes.
So this is very quickly I will go through. All of you know what are the differential features between the UC and CD. And in UC, it is always a continuous disease, start from the distal end, and based on that, Montreal classification is there. If it is only rectosigmoid or left colonic, or it is crossing the splenic flexure, then it is called pancolitis. Pancolitis can be till here. Pancolitis can involve till here. Ileum is usually not involved, but sometimes even if you have E2 disease, you can see a inflamed mucosa here on segmental biopsy. That doesn't rule out, that doesn't tell you it is a Crohn's disease, because this is called sickle patch. At the base of the appendix, you can see this type of finding in UC also. Please remember that. But rest of the areas will not have this type of changes. Okay. Usually rectal sparing we don't see in classical UC, but when you see that other biopsies from other side is normal, from the red zone is showing chronic active like changes with basal plasmacytosis, again rectum is normal. That is called rectal sparing disease. In those cases, we'll reserve our diagnosis and we can say it is unclassifiable IBD. Is that clear? That means it is indeterminate, and that, and on due course, after few biopsies for further radiological examination only, they can be reclassified. It is UC or Crohn's. So as I said, segmental biopsies are taken. If you take from the different anatomical location, in UC, ileum normal, then you see gradually the chronicity and activity are also increasing. So we see a right to left shift, all of you know, and ileum is usually not involved. So we can discuss, but mucosal biopsies, in Crohn's disease, you can see the patchiness already we have discussed. It is normal here, it is inflamed. This part is more inflamed. This part is more inflamed in comparison with other areas, that indicates patchiness. So all of you know how the Montreal classification is done. And also endoscopically, this ileocecal junction is ulcerated, but see ascending colon, it is again normal. Okay. Here you are seeing again loss of vascular pattern here. This is the normal vascular pattern you are not seeing. You are seeing ulceration. So it is in between, it is hiding and showing you the ulcers. So this is a patchy disease. And on full mount, what you can see, you see usually it is mucosa limited. Under the Crohn's, the inflammation can go deeper down like tuberculosis. On Crohn's, the ulcer can be deeper, L-track like this. And pseudopolypi can be seen on both, but it is more common in UC like this. Why pseudopolypi? Because there are longitudinal ulcers and the intact mucosa in between, which is inflamed and granulation tissue that actually pops up like polyp. That's why you call them pseudopolyps. And stricture in Crohn's look like this. That is usually not a feature of UC. Very rarely you see, we see some fibrosis, but that is very superficially identified. And this is a pericryptal microgranuloma, ill-formed, I have already described. What about the neutrophils? Now we are talking about the activity. So neutrophils, so you have all heard about the fecal calprotecting test. What does that indicate? Any idea? So you can see fecal calprotectin is positive. So you will see on your form, it is mentioned. So how do you interpret that? What does it mean? It means clinically the patient has acute disease. That means the patient have neutrophilic activity. So it is the clinical identifier of neutrophilic activity. Now, what are the endoscopic identifier of neutrophilic activity? Obviously, I have just described the endoscopic finding. There will be loss of vascular pattern, granularity, ulcer, erythema. These are the endoscopic indicator the disease is active. And then if we identify any form neutrophilic infiltrate, that is activity for us, histopathologist. Now, people used to thought endoscopy and histology always correlate, but that is not actually the picture. And you can see up to half of the cases during follow-up biopsies, when endoscopic thought that the mucosa has healed, there is no activity, but histologically neutrophilic activity has been identified. That's why identification and reporting neutrophilic activity very critically is important for us. That is a indicative that the disease is still going on. Is that clear? Now, how to convey it better? So there should be a grading system, and there are many grading system how to report or convey the neutrophilic activity. One is GBOIS system. It is usually used, it is validated system used for the clinical trials, but it is not very easy to apply routinely. Other is Roberts. It is also very commonly used in clinical trials. Now Nancy is one index that we also commonly use routinely in all cases in routine reporting. It is very easy. So how to interpret that? Grade 0, there will be no histologically significant disease. That means the mucosa has healed. So when we call something as healing, when the architecture even has become normal, no neutrophilic activity, no significant mononuclear cell infiltrate, no basal plasmacytosis, no eosinophilia. So all these 5 features is grade 0. Grade 1 means chronic inflammatory cell infiltrate is there, but no neutrophil. Okay? And this chronic inflammatory cell should be moderate at least. Grade 2 is mildly active disease. It is very focal. Here you can see when it is involving less than 50% of the crypt area. Moderate means when it is involving more than 50% of the crypt area. And severe, it is very easy whenever you are identifying any ulcer or erosion. It is Nancy grade 4. Okay. So first thing you have to see in your microscope very quickly, it is whatever we have discussed till now, that that approach you have to follow. And if you find a thing that it is IBD or UC, and then you find there is ulceration was there, that it is straight Nancy grade 4. Is that clear? So this is how grading is done. But all these grading system, what I have shown you, they have been made and validated for ulcerative colitis, not for Crohn's disease. So whenever you see Crohn's disease, you have to do something else. You cannot apply Nancy. So there, fortunately, in 2020, another grading system came. It is very easy, I will tell you. It is called DCS score. It has 3 components, D for distribution of the disease. If I compare here, so here the distribution possibly means chronicity and activity, both you have to see, possibly involving less than 50% of the total crypt area. So it is focal. So if it is less than 50%, it is D1. If it is more than 50%, D2. Secondly, chronicity. So C0 is normal, mild crypt distortion, distribution is the overall distribution, then chronicity you have to see. Chronicity means inflammatory, how much inflammatory load is there. So if it is mild crypt distortion, so then it is C1. If you are identifying marked to dense mononuclear infiltrate with basal plasmacytosis, so this is the only grading system which has incorporated basal plasmacytosis, which is one of the important finding to differentiate IBD versus non-IBD. That's why DCA is very important. So if you identify basal plasmacytosis with moderate to marked mononuclear infiltrate, it is straightforward C2. And activity means it is neutrophilic activity. 1 means only few neutrophil in the lamina propria. 2 matlab you are either identifying crypt abscess or you are identifying ulcer or erosion. So crypt abscess, ulcer, erosion, everything has been clubbed together as A2. So it is very easy to do. So if I do DCS score in this case, less than 50% involvement of architectural distortion, so D1. If I look at here, so there is basal plasmacytosis, C2, and there is neutrophilic infiltrate, which is infiltrating the epithelium significantly, but there is no ulcer, no crypt abscess, I will call it is A1. So you have to write like this. Okay, DCS score is this. On the other hand, if you look at this area, so other findings same D1, C2, but what we are seeing an ulceration or erosion. So what we'll call it is A2. This is how the DCS scoring is done. So all cases, either you can do UC, Crohn's, in both the cases you can do DCS score, or what we actually do, our clinician wants Nancy score or Nancy grading in UC, and we always mention DCA score in Crohn's disease. Please remember that. So come to our cases. So it was we have to actually, this is the full interpretation report you have to write. We have already discussed it is favoring UC. Now also Nancy Index grade 4. You don't have to do both, but if you are compelled to do so, you have to do also DCA scoring like this. So if everything is clear till now, any question? Or we'll go to case 6.
Is there any IHC marker to grade activity?
No, that is not recommended. Okay. Now
Yes.
case 6. Case 6 again, Shupriya, can you discuss?
Yes, sir.
So now we'll increase our speed because it is already 50 minutes. Okay, 42 female abdominal pain, multiple ileocecal ulcers.
Yes, sir. I could appreciate 5 fragments in this field, where I could appreciate focal mucosal ulceration
Okay.
with the surrounding normal look mucosa and chronic inflammatory changes also there. And
Okay.
mucosal architecture is distorted. The crypts are shortened and irregularly spaced, even branched. And in lamina propria, in the further slide in the lamina propria. So this much I could appreciate in this slide.
Acha.
And one lymphoid
Shupriya, one
aggregate is
thing,
present in the
everything,
one
okay,
focus.
everything was correct, but what you have to tell further, in this power, we can see both ileal fragment as well as cecal fragments.
Yes, sir.
That you have to qualify further. Multiple fragments you have told. You have missed again the scenario that if it is a diffuse disease of the ileocecal junction or it is a patchy disease. So what do you think
Patchy,
now?
patchy,
So it is
sir.
patchy. So
Yes.
you think it is a chronic cause, chronic disease, and it is patchy.
Patchy.
So what we can
Yes.
say at this power, this is a patchy chronic active
Patchy chronic.
ileocolitis. Because already you have seen the ulcer here. Okay. This is higher power just to help the others. So here we can see a lot of inflammation, architectural distortion, and this is more inflamed fragment, and this is neutrophilic exudate. Even if you see, don't see, what to say, this is a breach in the epithelial continuity. If you find neutrophilic exudate, that is also a sign of ulcer. Please remember that. Okay.
Yes.
And if you find breach along with this, that is more further better. So there is ulceration, so chronic active and patchy. So anything further
Yes.
you can suggest? Etiology, granuloma you have seen in this case.
No, sir.
So morphological features are just like either tuberculosis or Crohn's disease. Do you agree?
Yes.
Okay. That's why we should not tell what it is. We should always say kindly investigate further to determine the etiology. But in this
Yes.
case, we can determine the etiology. Possibly I have cheated with you. I will show you something on higher power. So this is the other inflamed fragment. You can see the colon, and these are the pictures I had given you. Now go look at this higher power. What you can see at this area, this is the same area. Anything else you can observe now? So this is the area of ulceration. Anything? Anyone?
Parasites.
Parasites. What are these parasites?
Looks like a Entamoeba histolytica.
Entamoeba histolytica, trophozoite. Now, if I say these are not trophozoites, these are histiocytes, how you will defend your claim? What are the defining features? Morphologically, obviously, I'm talking about morphology. You can always do pass with diastase stain, or you can do IHC. Okay? Those are there, but morphologically, what you will look for? So, yes. So I'll tell you, because time is less. You will look at the nucleus. In all cells, the nucleus will be hematoxyphilic or blue. However, amoebic trophozoites, the nuclei will be eosinophilic. Please, from now onwards, try to see that. And also in the cytoplasm, you know, there will be RBCs, but that can be also be found inside a histiocytes. Important finding that you will see eosinophilic nuclei in this case. Okay, so these are amoebic trophozoites. So this is actually an amoebiasis, but see how the morphology cheated you. It is a patchy chronic active ileocolitis, but it is due to amoebiasis. That means this type of chronicity and activity can be seen in other disease. Let us discuss another case. This is case 7. Anne-Marie, can you discuss very quickly? This is since 3 to 4 weeks abdominal pain with multiple ulcers, and the question was query IBD. This is a 53-year-old male. Anne-Marie is there? If Anne-Marie is not there, Srishti or Gulafshan, can you discuss?
Or any student can volunteer, any of the students.
Anyone, because we want to save time. Anyone?
You speak more, you learn more.
Otherwise, Vishnu Priya, you can tell what you can see.
I could see two bits of tissue, and
Yes.
it looks like a large bowel, and the crypts look somewhat enlarged, and there is some mucosal ulceration.
But we are looking at a lower picture, lower power picture. So what all you can tell at this power? So you said the crypts looking elongated. Anything else? So specific points I have already told you. If it is inflamed, architecture is distorted or normal, you talk from those points. Inflamed or not? If it is not, you can say not much.
It's not that much inflamed,
Okay.
sir.
Architecture?
Architecture is it somewhat crowded appearance is seen.
So crowding or expansion, anything is distortion. So if you ask me, this area is normal. This area is perfectly normal. They are pinching on the muscularis mucosae. Look at this area, slightly distorted. Look at this area, you yourself told the crypts are elongated. Okay.
Yes.
Here also there is some attempt of branching. Here also you can see side branching. So there is some patchy chronicity is there. Though inflammatory cell is not there like what you have seen already, many pictures we have seen. So possibly some patchy chronic disease. Now what you can see in this image was also given. Anything? So now you can appreciate the chronicity. Yes.
Sir. There is presence of crypt abscess and cryptitis in this slide.
So activity is also there.
Yes, sir.
So activity is also there. So now we can say this is a patchy, maybe patchy, mild chronic active colitis.
Yes.
Now how to differentiate IBD versus non-IBD? What you will look for?
Basal plasmacytosis we have to look for.
Okay.
There is
so this
yes.
is another image. This was given or not, I don't remember. This is the rectal biopsy. What you can see? This is what? Look at this area. Look at this area and determine what it is showing. This
So
is obviously the this is ulceration. Very
ulceration
nice.
is
This
there,
is
sir. Yes, sir.
exudate plus granulation tissue. The
Granulation
rectal
tissue
fragment
also
is completely ulcerated. Okay. So chronic active colitis that we have already discussed, possibly a patchy disease. So you will look for the eosinophilia and basal plasmacytosis. What do you think? First, see what I have told. Basal zone is present or not. Basal zone will only be created when the crypts are short. What do you think?
Crypts are short.
The crypts are short very focally, na?
Yes,
But
focally
then,
short. Yes.
so you have to tell focally basal zone. I think there is focally basal zone is there. Then you have to go into high power and see if basal plasmacytosis is there or not. Okay. Not much. Okay. These are actually lymphocyte, though I should have put a very high power image for you. Okay. There is no basal plasmacytosis. Then we cannot differentiate between IBD and non-IBD. And whenever we see this type of picture, we cannot rule out a possibility of non-IBD type of colitis. So if this is all, we also write this is a patchy chronic active colitis or proctocolitis, and possibility of a non-IBD type of colitis cannot be ruled out. Okay? But we always try to see if there is any other etiological clue. So what we should do, what we had done in this case, we had went into the higher power objective, and what we can see here, somewhere here, can you see anything? Anything here? These are all capillaries, no?
Endothelial cells. God.
What? This is not enlarged. These are also endothelial cells, but these are very small. So if you compare, this is very much enlarged, and there is some inclusion also. So what do you think? So cytomegalovirus.
Infection.
Exactly. So this is a case where we have done IHC and we are identifying many CMV positive inclusions. Okay. So saying so, it is a CMV colitis, again to show you and reinforce that patchy chronic active disease is not only because of IBD. If there is no clue, we'll say we cannot tell, you investigate further. This is another case number 843, male post-transplant patient presented with diarrhea. What do you feel?
Sir,
Chronicity or
there
not?
are some questions, sir.
Yes,
Sir,
please.
when to say crypt is elongated?
See,
Fine.
it is only a morphological appreciation, no? In the first, here you can see this is the normal crypt. Can you hear me?
Yes, sir. Yes.
There is some echo actually. Crypt is elongated. Whenever there is elongation, what we'll see? We'll see some tortuosity because there will be hyperplasia. And whenever there will be hyperplasia, we'll see some tortuosity of the crypts. So if you see tortuosity like this, then we'll say there is some elongation of the crypts. Like this is almost straight crypt. Here you can see this is a very much oriented area. But if you compare here, there is some branching and some tortuosity also. These are the indicator of crypt elongation. Now,
Sir,
here,
can chronic
yes,
can chronic colitis show a villiform surface? Focal villiform
exactly.
surface.
I already told chronic colitis always in the colon also can show you villiform surface. Okay? So that is also indicator of chronicity. So chronicity can be seen in the crypts, chronicity can be seen in the surface also. Villiform change also indicates chronicity. So anyone can very quickly tell if there is any disease or not in this case, architecture maintained or not. Quickly. Now you should be very quick. Architecture? Anyone? Supriya, you can also tell.
Propria.
Architecture maintained or not?
Not
Is it a tough question?
started.
Yes, I cannot hear you. Can you repeat that? Architecture normal or abnormal?
Abnormal.
Distorted. So it is very clear. Architecture is distorted. There are branching, dilated crypts, elongated crypts. This is also branching. At places there is no crypt. That is, all these features are chronicity. Mucosa is inflamed or not? Very mild, no? So let us see. This is a chronic colitis post-transplant presented with diarrhea. Crypt distortion is seen. Yes?
So 5 fragments. Yes,
Yes,
sir. 5
yes,
fragments
yes,
of
go
the
ahead. Actually, your voice is breaking, okay? We cannot hear. There is some network problem. So we'll go ahead. So 5 fragments, and it is very well
crypts are
taken. There is a
dilated or distorted, sir. So it is distorted. Distorted, sir.
distorted. Yes. How much is inflammation? Very mild? We have heard that the crypts are distorted. Now I am asking, the inflammation is? Okay. What about inflammation? Can anyone tell me if there is mucosa is inflamed or not? Draw a line. See if the similar inflammation is there in both the zone. Your voice is breaking. Whoever is speaking, I cannot see, but your voice is breaking. The others, you can also speak up, no? What is the issue? So, density of inflammation, though it is very mild, but you can see similar density is present in both the areas. That indicates there is redistribution. Otherwise, you would have seen more inflammatory cell in the upper half and very few in the lower half. Okay? So it is mildly inflamed. We cannot hear you, okay? Your voice is breaking. So I am sorry, I will go ahead. And you can see this is the surface mucosa which is looking flattened and injured, and there is ulcer or not, we have to see. Okay?
Yes,
Now what about
inflammation is there in lamina propria. Patchy, sir.
Okay.
Yes, inflammation is there.
What about basal plasmacytosis? You just answer me. Okay, that will save our time. If there is eosinophilia and basal plasmacytosis, we all already have seen it is a chronic colitis. What about basal plasmacytosis and eosinophilia?
I think
Present
that
or
there
not?
is lag
Not
at her
present.
end.
Her
Yeah,
network
there
is not
lag.
proper. The others, that's why I am asking the other student. You can also
Not
speak
present.
up. Yes. Any other student?
There is no basal plasmacytosis noted in
See,
this
whenever,
diagram.
okay. So I will just explain for the others. So wherever the crypts are there, there is no basal zone. Somewhere the crypts are not there, but lot of plasma cells are not there. What about
No,
eosinophilia?
sir. Yes.
Eosinophilia is not there.
Not
So
there, sir.
our indicators are possibly not there. So we'll think though it is a chronic active colitis, possibly this is non-IBD type. So what do you think? What it can be? In a post-transplant patient, what can be the feature? Look at this picture. What is missing here? Compare with this. What is missing in this
Non-IBD.
fragment of anything, any observation? You have to learn to observe. Which structure is missing in this? If you compare with this fragment, what is not
Crypts are,
there? So
crypts
crypts are
are not
not
there,
there.
sir.
So
Not
if in a post-transplant patient, we see a mucosa which is ulcerated and a large patch is not showing you crypt, what you will think of? At least suspect and ask the
graft versus
clinician.
host.
Yes, exactly. Graft versus host
Graft
disease.
versus
So
host scanning.
exactly. So
Yes.
you have to go into high power. You have to look for lymphoepithelial lesion. You have to see if the crypt apoptotic activity is high, apoptotic abscesses are there. Eosinophilia may be seen sometimes, but basal plasmacytosis usually are not there. So this is actually an example of GVHD. Again, to tell you that you can see this type of picture in many other diseases. So anything, any cause, may it be drug, may it be an infection, may it be a chronic repetitive ischemia or repeated doses of radiation therapy that can injure your mucosa, cause neutrophilic infiltrate, and when we are not giving the radiation in between 2 cycles, then the mucosa will heal. So if you take a biopsy after that, what you will identify? There is feature of chronicity and activity. So all these causes can show you chronic active colitis like features. That's why all of them are differential diagnosis of IBD. But in none of these, usually we see basal plasmacytosis or eosinophilia together, not only eosinophilia. So this is actually acute and chronic ischemia. This is acute mucosal infarct, and in the adjacent area you can see healing and branching. That's why chronic active like change. Okay. This is a radiation colitis, induced colitis. You can see a lot of chronicity and surface ulceration. This is a diversion colitis. You can see in diversion colitis, in the pouch, you will see lot of lymphoid aggregates. That is the common finding, and that's how we know that it is a diversion colitis or it is a pouch. You can see chronicity and activity. Okay, that's how we differentiate. Other differential diagnosis, it can be a CVID, just to tell you. It can be CVID may IBD like colitis, you can see. You can also see cryptitis and crypt abscesses, but mature plasma cells are not there. An associated infection we commonly see like GID and all. It can be a cord colitis, or most importantly for you, in all cases, if it is not ruled out, please consider a possibility of DISE, that is drug-induced enteropathy syndrome. Very commonly NSAID-like feature or IBD-like features can be seen because of the chronic NSAID intake or MMF intake, or nowadays we can see this type of changes because of immune checkpoint inhibitor therapy. Okay, in all of them you can see a lot of neutrophilic infiltrate, lymphoepithelial lesions, some distortion. So these are common findings. So please remember all these differential diagnoses, and with that I will try to go into the next one. So we'll very quickly discuss case 9, or I can discuss. So this is a
Sir,
case
two
9.
fragments of
Yes.
tissues are there. Colonic mucosa is present, and with preservation of the crypt architecture, these are parallelly arranged and
Please
evenly
stop there.
spaced.
Do you really think the architecture is preserved? Just try to see
So
what we.
overcrowding is there, sir, and decrease
So
in the spacing
overcrowding is
also
not an
there.
architectural distortion,
Yes, sir. Yes, sir.
isn't it? So
Yes, sir.
overcrowding is also distortion. All these areas are distorted, and
Yes, sir.
shortening of the crypts. Can you see here? So that is
Yes,
another
sir.
form of distortion. You may or may not see patchy loss of the crypt. And
Yes,
what
sir.
is another important finding? Look at the surface. Anyone,
Ulceration is there, sir.
another friend of
Surface.
yours asked me if there is villiform change. Is that a feature of chronicity? Can you see the villiform change on the surface? That is also an indicator of chronicity. Is that clear? So there is chronic disease, chronic colitis. Now, activity we can't say in this power. Inflammation is looking like there is some inflammation. This is the
Yes, sir.
basal zone. Do you feel there is a lot of plasma
No.
cells here? It is
No,
looking
sir.
quite clean. Okay,
Yes.
no plasma cells. So it is looking very clean. But there is chronic
In
colitis.
Lamina propria, I could.
Shupriya, we cannot hear you. Your voice is breaking.
Plasma cells and
Where's
more.
the-
Sir, in Lamina propria, lots of
More-
lymphocytes are there,
Okay.
and some plasma cells are also present.
Anything you can see
And
in
I
this
could,
picture? Tell me that.
In sir, intraepithelial lymphocytes are also present in these slides.
That is a very good observation. So when we say increased lymphoepithelial lesion, at least in one crypt, if you are seeing 3 or more lymphocytes,
More than 20.
that is another definition.
So
But
more
if you
than
see,
20 lymphocytes per 100 epithelial cells,
but
we
in
could
crypt,
appreciate in that.
that is in the surface epithelium. But in crypt, if you see more than 3 lymphocytes per crypt, that is increased lymphoepithelial lesion. So increased lymphoepithelial lesion can be seen because of various causes. It can be seen IBD also. You can see in NSAID. Just we discussed, it can be because of mycophenolate therapy. It can be because of various autoimmune disorders. Okay. Now, in this case, there is some chronicity. Though there is no basal plasmacytosis eosinophilia, we are seeing lot of lymphoepithelial lesion. And what are these areas showing? These clear bags with some structure in their cytoplasm. Can you see here within the epithelium? What are these? Anyone? These are the apoptotic bodies. Okay. So we are seeing lymphoepithelial lesion and lot of apoptotic bodies. So any clue? So this is a chronic disease. Yes, Dr. Shilpi told it is apoptosis, correct, with lymphocytic infiltrate, and they are causing cell damage. So it is not just a bystander. So what do you think? It is IBD or not? Because those vital signs are missing. So what do you think?
Sir, lymphocytic colitis it can be.
Lymphocytic colitis में architectural distortion नहीं होता है. So here the disease is chronic because there is architectural distortion. Is that clear? It is a clinically also Crohn's disease. How does the microscopic colitis present with? It is silent endoscopically. It is silent clinically, not exactly silent. The patient will present with watery diarrhea, profuse, but endoscopically it will be normal. So only diagnosis is made under microscope by looking at the thickened basement membrane or increased lymphoepithelial lesion. But architecture will be normal. ठीक है ना? Here architecture is abnormal plus microscopic lymphocytic colitis like feature. That is not a feature of microscopic colitis. So something else. Can you see lot of lymphocyte here with lot of apoptotic debris? And if you do a apoptotic marker like H2X, you can see all these dots which are highlighting the apoptotic bodies. So no basal plasmacytosis that we have already seen. So this is actually a patient, 21 year when she landed into our hospital, but she was suffering since 2017 and she was diagnosed 2024. And see, she had multiple episodes of atopic dermatitis, sometimes hyperbilirubinemia, only once that became normal, but she had hyperproteinemia and multiple episodes of fever, anemia, hyperproteinemia. Then in 2021 and onwards, she also had small bowel disorder, which was once thought to be, because of this increased IELs, one thought to be celiac disease, but did not respond to your GFD. Also thought to be ATT, someone reported outside because looking at the altered architecture as possibly tuberculosis, she was mistreated with ATT, then as a Crohn's because it is a chronic disease, but the disease keep on progressing. Can you see? And also the ulcers and everything become deeper and she become very ill. And when a morphological diagnosis could not be done, a sequencing was done, and what was identified? It is a CTLA4 exon 2 mutation. And CTLA4, what it does, see, there is always a crosstalk between the APC and T lymphocyte. All of you know, CD4. And this crosstalk is between the T cell receptor and MHC, isn't it? And this is the initiator of this crosstalk. But to keep on the immune system active, you have to have this co-stimulatory mechanism, that is through the CTLA4 and CD8T and 86 receptor on the APC. Actually, exon 2 mutation stops this crosstalk. समझ गया ना? So if this is not there, though there is initiation, your immune activation cannot be maintained. So, ठीक है? Or immune dysregulation, actually this is actually a factor which causes regulation of the immune system. So that is actually lost, and patient will have excessive immunity and they will present with CTLA4 haploinsufficiency related colitis syndrome. And if you find now onwards any patient who has a IBD like chronic disease over years and this type of lymphocytic infiltrate with lot of apoptosis, please keep in your mind it can be a CTLA4 mutated, or patient may be a cancer patient had been given CTLA4 anti-CTLA4 therapy. This is a very specific finding, but can be seen in any other disease. So this is one example. So saying so, I just want to mention that if you look at when, at which age the IBD occurs, so we all know 20, 40 or more than 60, all of us know. But sometimes IBD can be seen within 24 days also, very early, that is called neonatal, or first 2 years of life, that is called infantile IBD, or when it is more before 6 years or within 6 years, it is called very early onset IBD. So infantile and very early onset IBD, if you find in your practice anytime, you have to keep a possibility of monogenic IBD. Okay? And monogenic IBD, because these are some specific gene mutation which regulate the immune system, these patients, usually these are rare, not every day we'll find, once a while, and it has very heterogeneous clinical presentation like the patient I have just shown. Histological features are unlike a classical IBD, but the patient behave like IBD, chronic debilitating ulcerative disease, and it is difficult to treat. Example you have seen, nothing was working in this patient. And this is the taxonomical classification of monogenic IBD disorder. I don't want to keep you through this classification, but please remember, anything which can alter your Treg mechanism or immune regulation, like in very early onset, if the IL-10 gene is mutated, then also the patient can develop very early onset IBD. Or CTLA4 gene mutation, I have told you, in IPEX syndrome, XIAP syndrome, you can see this, where lot of apoptotic bodies you will identify, and FOXP3 gene mutation in IPEX syndrome. These are commonly patients presents like this. So these are called monogenic IBD. And if you find a chronic debilitating patient, not very classical of IBD, it is a actually, if you look at the ESPAGEN recommendation, they have already started doing genome sequencing in these all difficult to treat IBD like chronic debilitating disease, especially in children. So especially in children, this type of presentation, we have to do sequencing, and then we have to see if it is a monogenic IBD or not, because in this, whatever we have discussed today, those classical histology may be missing. So that one thing you have to remember. So what we discussed today, you have to follow these steps. Mucosa inflamed or not, whenever you are looking at a biopsy, look at architecture. If it is diffuse or it is a focal, then decide it is only chronic active. Then look for basal plasmacytoid eosinophilia to decide if it is IBD or not. This rule only will not apply if you only are getting a ileocecal biopsy, or in case of very early onset or monogenic IBD. Okay, then you favor an IBD in all other cases, but diagnosis only you can favor because it is a diagnosis of clinical endoscopic radiological correlation. Okay, we have talked about the microgranulomas that will help to further classify the disease. You have to also classify if it is a UC-like, look for diffuseness or patchy, and also look for the microgranulomas non-cryptolytic. Classify accordingly, look for any other associated infection. Even in IBD on follow-up on immunosuppression can have CMV infection. That's why it is a dictum. If you have clinically aggressive disease or the disease flare, or acute severe ulcerative colitis, if a biopsy has been taken, then you have to do at least IHC along with morphological examination for CMV. Okay, so that you have to do, and always look for dysplasia. So please follow this algorithm, and interpretation are highly dependent on biopsy. Always we have to discuss with our clinical fellows. The importance of segmental biopsy I have already told, and it is always better if all these segmental biopsies are separately labeled and sent to you, and you have to then also report separately for each segment. Okay, if it is a chronic active here, basal plasmacytosis is present or not, like that everywhere, and granulomas are present or there, then you give a final interpretation. And Always please remember, it is not done in all hospitals, but if you do mount the biopsy on a filter paper, it will be easy, might be easier for you to get a oriented fragment that you can practice, and always discuss with your gastroenterologist and endoscopic, sir, from which site you have taken biopsy. There can be diagnostic dilemma, and in DT you have to ask if you have taken a just and from an area of loss of vascular pattern, or an area where you were seeing deep ulcers, erythema, nodularity, etc. Because see, there was a correlation study, and it was found that when the mucosa is like this, all features what we have discussed to the histological features, they were more identified here. If the biopsy is taken from normal area or just from a area of loss of vascular pattern, then you will identify these features very less. Okay. Last case, anyone want to discuss what you are identifying? So this is just spotter. Architectural distortion.
Distortion is there. Yes, sir.
Okay.
Crypts are also dilated and
Dilated.
yes, sir. Some crypts are elongated also. So I could appreciate tubular pattern and villus pattern. So can it be tubular-villus pattern?
I will tell you, this is a rectal biopsy. Okay.
Yes,
and if you see this type of architectural distortion with villiform change, it is obviously chronic proctitis. I will also tell this is actually known case of UC on follow-up. Now this is a known case. In known case also, you have to try to see if there is basal plasmacytosis or not, eosinophilia or not. Because basal plasmacytosis is not only helps you to make a diagnosis, but it also corroborates with the disease clinical activity. If it is not clinically active, but we are seeing basal plasmacytosis, we have report that, because this patient can have another episode of clinical active relapse. Okay. Now you are talking about dysplasia. What you are talking about? Are you sure there is dysplasia?
so another focus, I think one picture was given where I could
this
appreciate.
was given to you.
Yes,
So
sir.
dysplasia, low grade, high grade.
So low grade, because stratification less number of mitotic figures here, and loss of blood is also there, sir.
Okay, I
But
have
the
a specific
mitotic
question.
activity is
Okay,
less.
okay, I understood. So tell me, it is IBD associated dysplasia or conventional dysplasia or non-IBD associated? Do you know the difference? You understood my question? IBD associated dysplasia means it is already a known case of UC. The dysplasia is because of the IBD or not? That we want to know. Non-IBD dysplasia, even if the patient is a known case of IBD or UC, patient can also develop a sporadic adenoma. So that is non-IBD associated dysplasia. So looking at this morphology, can you, that we have to tell as a pathologist. So can you say it is IBD associated or not? So we can say. So I will tell you. So first you have to see this image. So this is how sporadic adenoma look like. This is IBD associated dysplasia look like. In sporadic adenoma, what do we see? Top heavy pattern. Always now onwards, you try to correlate. In all biopsies, you will see the dysplasia starts from the surface and then it comes down like this. Okay, that is how the sporadic adenomas look like. But in IBD associated dysplasias, we see a bottom up pattern like this. We usually see the dysplasia, which is usually identified in the crypts, but not on the surface. And in addition, here, all other adenomas, sporadic adenomas, you will not see architectural distortion like a IBD. So the architectural distortion might be present. There can be expansion of the stroma, and you can also see, just like in other IBD, you can see a lot of inflammatory cells here. So by doing permutation and combination in a known background, like in this case, we'll say this is a IBD associated dysplasia. What is the importance here? Development of high-grade dysplasia and carcinoma chance, it is very less. And you know, over 10 to 20 years, maybe 10 to 15 years, a very small fragment of disease develop carcinoma. Here, within 4 to 5 years, patient can develop a carcinoma. That's why if you identify dysplasia, you have to tell if it is IBD associated or non-IBD associated. And also, you have to say it is a sessile or it is a pedunculated, because your management depends on that. And high grade, low grade, very minutely you have to see, because if it is a multifocal low grade dysplasia or it is a high grade dysplasia, then colectomy is usually advocated. So please do it very critically, and if you find or if you think it is a high-grade dysplasia, always take an opinion of your senior colleague. That is how it works. Okay, so I will not go into detail. So I hope you have learned something today. So take-home message was what we have learned. Some histological features are definitely there. It is not so non-specific. You have to know to differentiate between IBD and non-IBD. And what is most important, segmental biopsies. The orientation is important. We have to know the endoscopic, radiological detail and clinical detail to correlate and say if it is a diagnostic or it is just a histological favoring point. Histological mimickers, please keep in mind. And always you have to look for basal plasmacytosis, eosinophilia together, not only eosinophilia. And then you have to favor IBD associated, non-IBD associated. Pathology should not use dubious terminologies, like consistent with terminology is not recommended. Only using a colitis is not recommended. Okay? So specific terminology like colitis NOS, you should not use this type of terminologies, and grading of activity you should always do. So with that, I will stop and I will invite Dr. Survi to comment on this, and then we can have more questions. Survi, you are muted.
Okay, good evening all. Thank you, Dr. Prasenjit sir. It was such a comprehensive and lucid talk. You covered in very detail about all the nuances of diagnostic approach of IBD, how to make the diagnosis, how to differentiate IBD from non-IBD, and further subclassification. And sir, I think you have covered all the aspects. I just want to emphasize that of just few important points, that it is very important, first of all, that the biopsy on which the diagnosis should be made should be pre-treatment. It should be a treatment naive biopsy. And most of the times patients come to us and they have already taken some steroids or some kind of treatment outside. So the biopsy of IBD should never be made on a post-treatment biopsy. It should be treatment naive biopsy, because at times the treatments can alter the morphology, and it can alter the suppose if it is a case of pancolitis, but the patient has already taken steroids from from outside, it can lead to some patchy resolution of the disease. So it can alter the morphology, and it can lead us to misdiagnosis.
And that is a very common scenario. And we
Yes,
have
sir.
seen that the patient had a known case of UC. After treatment in some other hospital, the diagnosis was suddenly changed to Crohn's
To
disease.
Crohn's disease, yes, sir.
It should never be done. You have
Should
to
never.
ask for the block and slides. You have to see yourself. If you are not in that position, never change the diagnosis.
Yes,
Okay?
sir. And,
So
and
that
many
is how
times
it
we get a
works.
request from the clinicians that whether it is now the diagnosis, it was misdiagnosed as UC, and now probably it is Crohn's. So we should never, do that, and we should ask for review the index biopsies. So that was very important. And sir, of course, as you have already very nicely emphasized, that we need a detailed clinical history, correlation with the colonoscopic findings and imaging, and of course the history of drugs and all other factors which can mimic IBD. That is very, very important. And sir, another important thing is, like whenever we are seeing any case of acute severe colitis with ulceration, whether the patient is a known case of IBD, sir, by default, we always, if we are seeing a severe ulceration on the biopsy, we put IHC for CMV always. At times, the clinicians are not suspecting CMV, but the IHC for like it comes out beautifully positive.
So now
So
we are also taking out a recommendation guidelines for our pathologists, Indian pathologists, in Indian Journal of Gastroenterology, that will come in first week of January, I guess. We have clearly said if the patient has acute severe ulcerative colitis, or if you find on the form it is written as steroid resistant UC.
yes, sir.
Okay, in
If the
these two
patient not
scenarios, you have
responding,
to always do either
yes,
a PCR or IHC.
or IHC, yes, sir. Patients if they are not responding. And so then another important point is, like, so often we get an with a like ileocecal biopsies with a differential of Crohn's versus TB, and we just see features of chronic active ileocolitis, and there are no granulomas. In those cases, we always so take deeper sections always to look for granulomas. So like at least we order 2 to 3 deeper sections, So that, and we have found that initially we did not find granuloma, but on deeper sections we are able to find
So
granuloma.
that I forgot to tell. In all ileocecal biopsies, if we are seeing patchy chronic active ileocolitis, in all cases we also take step cuts. So
Yes.
before taking a step cut, you cannot sign out.
We cannot,
So,
yeah, if there's
yes.
suspicion of Crohn is there, it is mandatory to take step cuts or deeper sections to exclude the presence of any granulomas. And sir, then of course it is very important to grade the activity in all the known cases of IBD, because the target of the treatment is not only endoscopic remission, it is mucosal remission as well. And often there is a discordance between the endoscopic and mucosal healing. So it is important that we tell the clinician that there is no activity on histologically, so they can either downgrade the treatment accordingly. And so one thing here is I wanted to clarify, like there is a difference between quiescent colitis and complete mucosal healing. In complete mucosal healing, even the architecture has also come back to normal, whereas a quiescent colitis, if it is just showing some basal plasma lymphocytosis with mild architectural distortion but no activity. So what is the clinical implication of
actually
that?
a follow-up biopsy I could not discuss because there will be shortage of time.
Yes,
so
sir.
we use a 5-tier reporting system. So as you have said, everything can be normal.
Yes,
There is
sir.
not much inflammation. Even architecture has gone back to normal.
Normal.
Okay, the Crypt architecture. So
Yes,
it is then histological healing.
yes,
There can be
complete.
another scenario when there is no neutrophilic activity, but architectural distortion is still there.
Yes,
with mild inflammation.
yes.
So that is called quiescent colitis. Here also you have two subgroups.
With and
You are seeing
without.
quiescent colitis with basal plasmacytosis with eosinophilia,
Yes,
and
yes.
quiescent colitis without basal plasmacytosis or eosinophilia. You have to exactly report like this. If already I have mentioned, I should have emphasized, quiescent colitis with basal plasmacytosis is definitely going to have a clinical recurrence in near future. So that's why it is important. It correlates very well with the neutrophilic activity, or it precedes actually the neutrophilic activity. Okay. So these two tier system, then comes the neutrophilic active disease.
Then
Then
mild
you have to
moderate.
yes.
That
And
we
there then also you have to always tell it is a active colitis. You have to always give score and grade, and you
Grade.
have to also tell if there are basal plasmacytosis or eosinophilia still present or not, because that is also a indicator of after treatment response.
Yes.
ठीक
Okay.
है ना?
So we have
So
to
this is a 5-5 tier.
5-tier reporting.
Histologically normal, quiescent without this feature, quiescent with this feature, active disease with this feature, without this feature. So these are the 5-tier reporting system.
Yeah. Okay, sir. And sir, we normally use that Nancy histological index for
UC,
grading the activity.
for Crohn's, you can do DCA as I mentioned.
Yes, sir. Okay, sir. And sir, then there is, sir, like many of these patients, they undergo sir, pouch anastomosis, resection, colectomy followed by ileoanal pouch anastomosis. And then we get biopsies from the pouch to look for pouchitis. So, sir, what is the if there is a pouchitis and they are saying that the patient was probably a known case of ulcerative colitis, and we are seeing activity with severe ulceration. So it has a very important
See, it
implication
is a
for
very
the
important area
clinician.
you have highlighted. I will tell the students what is a pouch. Pouch means your rectum is out. Your
Yes.
anal canal was there.
Yes.
And now you have made a pouch in place of rectum with your ileum. It can be a J pouch, it can be S pouch, side by side anastomosis. So it is made of ileum. So if you get a ileal pouch biopsy, that means you will see ileal mucosa. Now in pouch, as your intestine is already short, so short bowel segment, so there will be a lot of short bowel segment. It causes, there is a lot of inflammation. So what you can expect in pouch, there will be always some pouchitis. Again, the inflammation can be chronic, it can be active, or it can be chronic active pouchitis. When do you know it is not a recurrence of UC? Because now you have made a pouch. Normally ileum is not involved in UC, but a pouch can be involved by UC. Okay, so how to differentiate between if it is a chronic active pouchitis or a recurrence of UC? You have to see now there are those multiple lymphoid aggregates or not. If lymphoid aggregates are there, most possibly what you are seeing, this is just a pouchitis. If all other findings are seen, but I will tell you, it is also not so easy as I am saying. You have to see multiple pouches and you have to compare them serially to decide if it is just a chronic active pouchitis or it is a recurrence of UC. It is a gray area, but if you are finding lot of lymphoid aggregates, for the students, you can think that it is chronic active pouchitis, not a recurrence of UC in the pouch.
Okay, and so that is very important. At times we get, they say that probably if it is pouchitis, then probably it was not UC, it is probably Crohn's disease. That request also comes, sir.
It is also not so simple
Yes,
because pouchitis occurs more commonly in Crohn's, but
in
it can be
Crohn's.
seen in unclassified disease. You can see in UC also. So it is not true. But also, like we talk about the most common things more, the clinician also think like that.
Yes, sir. And so then, of course, rest everything was beautifully covered. And sir, we avoid using the term indeterminate, IBD
On
indeterminate. That has
biopsies.
to be reserved for resection specimens and not for biopsies. But at times, sir, the clinician is very strongly favoring, suppose, ulcerative colitis over Crohn's. But on biopsy, we are not seeing like those features of pancolitis, or we are not able to categorically favor ulcerative colitis or Crohn's. In that case, we say IBD unclassifiable, and probably we keep the patient
Yes.
on follow-up and ask for a repeat
Actually,
biopsy.
strictly speaking, unclassifiable means you cannot classify based on available findings.
Yes,
It
sir,
is not
yes.
equal to indeterminate disease.
Yes.
Indeterminate only on resection
Resection,
specimen, and
yes.
that is a scenario, 5 to 10% of IBD can be indeterminate. So unclassifiable is not exactly like indeterminate.
Yes.
Indeterminate diagnosis only based on radiology, clinical, and resection specimen, and they are treatment difficult group.
Yes, yes, sir.
Mm.
So that's all, sir. I think you have covered everything in so much detail. So, and it was beautiful,
So thank you,
sir.
Survi, for highlighting all those important areas. So
Yes,
now we
sir.
can refer to the moderators and we can answer together if there is any other question.
Yes, sir. Thank you, sir, for the wonderful seminar, and Sylvie ma'am for those inputs. So there are a few questions. One has asked, can you please repeat which all categories are included in monogenic IBD?
I could not hear you, ma'am, clearly. Your voice is not very clear.
Sir, which all categories are included in monogenic IBD?
Ma'am, monogenic is a clinical scenario, and when there is exome, on exome sequencing, you identify those specific mutations, what I have told, almost nearly about 70 aspas genes are there, which can be mutated, and this type of disease can occur in very early age. So those diseases are called monogenic IBD. So monogenic, it is not a histological term. Histologically, you are seeing some chronic changes, and exome sequencing, you have found there is a specific mutation, then only it will be called as monogenic IBD.
Then what are the features of dysplasia?
Ma'am, dysplasia, though, it is similar to all other intestinal biopsies only. Like she had identified, there is some nuclear stratification, there will be loss of goblet cells. Sometimes we also see hypermucinous crypt with dysplasia. So dysplasia can be another topic. There are many types of dysplasia. We cannot tell everything on this, but I will just say how to differentiate low grade and high grade dysplasia. One is nuclear architecture, but most importantly, side by side, you have to also look at the outer architecture of the crypts. If you feel the crypts are just like normal, rounded outline with dysplastic chain, that is low grade. If you are seeing Chinese letter pattern, there is architectural complexity and crowding of the crypts, and they're accommodating each other, those out pouches, along with nuclear changes. Even if it is low grade, that is actually a high grade dysplasia. So architectural abnormality is very important along with nuclear features.
Sir, and how to orient the mucosal biopsy?
Ma'am, orientation, actually it is a joint effort by your endoscopist and you. So they should mount but not always mounting is possible, because in they say it takes time. In private hospital, it may increase cost. So for us, when we get the biopsy, it has been fixed for 6 hours. The mucosa is already contracted. And how does it contract? Normally, when it contract, normally mucosa is like this. There is muscularis mucosae here. So whenever you put that in formalin, the muscularis mucosae, it contracts more because it has higher protein. So it contracts always like this. That mucosa is on the outer side, and the concavity that is formed by the your deeper surface, okay, muscularis mucosae. So if you can have a technician who is quite experienced, you can also identify this concavity and convexity, and accordingly you can determine that this is the mucosal surface and this is the basal zone, and you can orient like that.
Sir, we can also sir, use some specialized filter papers and polylysine coated papers by which we can stick the biopsy on the paper so
वही तो
that
बोल रहा
it
था,
keeps
but
it
that
different.
people usually not always like to do so, but you can do.
So
But that
we do for
also,
duodenal biopsies, especially
yes,
like
yes.
for celiac disease, to keep them orientation.
And you remember
To assess the
cucumber
villus
and
architecture.
okra and cucumber. What is
Okra and
okra?
cucumber.
Okra
Yes.
is bhindi. People cut a cross section of bhindi, fix in formalin, that acts like a mounting media, and then put the mucosal fragment on that, orient like that, and whenever you are embedding, you can put as such and cut through. So that is called, that is another more form of or way of basically orienting. Anyway,
And sir,
any other question?
Yes, sir. How to assess thickened subepithelial collagen and collagenous colitis? Thickened subepithelial collagen.
Thickened subepithelial collagen, ma'am, we always identify. See, sometimes when the mucosa is cut obliquely, or epithelium is cut obliquely, how the epithelium is like this. You have should have nuclei like this. But if I cut it obliquely, what we see? Cytoplasmic extension like this. Okay. So that may often be mistaken as thickened basal membrane. But if you just close your condenser, you will be able to identify that there is no glistening river-like thick collagen band. So whenever there is a collagenous colitis, if you close your condenser, you will see a glistening thick collagen band that is there, and also that is incorporating the smaller capillaries which is present just in the submucosa or subepithelium. Okay, not submucosa, subepithelium.
We can put special stains also, like to highlight.
हाँ, वो तो कर ही सकते हो, empty कर सकते हो, but morphological I am telling.
Yes, yes.
Then in cases where inflammatory granulation tissue is present along with colonic bits with mild chronic active changes, not diagnostic of any IBD, can we use ulcero-inflammatory lesion term in impression?
Yes, you can use.
We can use.
You can use, but it is not a specific disease entity that you know.
Yes.
So you can use that. Many a time we also see only ulcer and we see some stricture and fibrosis. So we say it is an ulcerostricturing disease, but we always write further etiological diagnosis is not possible on this.
And sir, is fecal calprotectin specific for IBD?
Fecal, it is not specific for IBD. I already mentioned calprotectin only tells you neutrophils are there in the lumen or not. So whenever there is active disease, even in acute infectious colitis, if you do calprotectin, that will be positive. Okay, so you should be very clear. Calprotectin positive लिखा है का मतलब है there is some activity. That doesn't tell it is active IBD or active infection.
That is all for the questions. Thank you so much, sir.
So thank you so much.
Covering the spectrum of IBD. Very
Thank you, Prasanjit, very much, and thank you, Surbhi.
Thank you, sir.
Thank you, sir, for the opportunity.
No,
Thank you
thanks
so
to
much.
you,
Thank
for
you,
both
sir.
of you, for taking your time and so passionately teaching all of us. There are still so many people in the audience, they don't want to leave you maybe. But thank you very much. And
Thank
just
you,
a small
sir.
notice for before I give it to Sonal, a small notice that next week we have 2 classes on hematology. One is on which instrument do you buy, 3-part cell counter or a 5-part cell counter, and why? So we have two leading hematopathologists talking on that. And we'll have students in that. So we'll have kind of a debate, questions and cross questions, which one is good for the lab and maybe for a hospital setting, 3-part versus 5-part. And then another talk by Dr. Anil Handu on quality assurance in a hematology lab. So we have 2 talks on hemat next week.